To panel 2 on social science perspectives on the COVID-19 pandemic. This is sponsored by the Academy for the Social Sciences in Australia. The title for this panel is "Which Health Policies and Medical Strategies Will Help Us Emerge from the Pandemic?" I'm the moderator for this panel. My name's Janna Thompson. I'm from La Trobe University. I'm a professorial fellow there. I'll introduce the panelists first. The first person who will be speaking is Dr. Stephen Duckett, who has held senior healthcare leadership positions in Australia and Canada, including the Secretary of what is now the Commonwealth Department of Health. He is currently Director of the Health and Aged Care Program at the Grattan Institute. The second speaker will be Laureate Professor Peter Doherty, who is an Australian immunologist who has worked with Ralph Thinkernagel of Switzerland and received the Nobel Prize for Physiology of Medicine in 1996. He continues his research and has been a very important public figure during this time of pandemic. And he's recently written a book called Insider's Plague Year. A third speaker will be Professor Nancy Baxter, who's head of the Melbourne School of Population and Global Health at the University of Melbourne. And she's clinical epidemiologist and the health service researcher. And the last speaker will be Professor Patrick McGorry, who's an executive director of Oregon Youth Mental Health at the University of Melbourne and is founding editor of the journal Early Intervention in Psychiatry. Now, the question and answer period will be after the speaker is finished, and you're invited to use the Q&A button in order to enter your question. Use that rather than the chat button, although of course you can chat as well. And then if any of the panelists during the question and answer period want to speak, you can either use the yellow hand button or just raise your hand. I can see everybody. So the first speaker is Stephen Duckett, who's presently the director of the Health and Aged Care Program at the Grattan Institute. Thank you, Stephen.
Thanks, Janna. So I'd like to start by saying that where I am sitting here is the unceded lands of the Wurundjeri people of the Kulin Nation, and it's an issue I'll come back to in a minute. I've got some slides to show you, so I'd like to share my screen, and here we go on. So the topic of this panel is which health policy and medical strategies will help us emerge from the COVID crisis. Now, it's interestingly phrased because it immediately draws attention to this word us. Who is us that we are talking about here? And we did a report on COVID last year, another one this year. And what we know is that about 41% of the population are at elevated risk of, if they catch COVID, if they're infected by the coronavirus, of having poor outcomes. So depends whether we're talking about us as the 41% or us as the 59%. And when we talked about, in our reports, we talked about it was safe for opening up if 80% of the population and 95% of the most vulnerable population had been vaccinated. So we had a threshold of the whole population and a threshold of the 41% possibly of the population. Now, I should declare an interest here because the 41% includes me. So I'm talking about us as that part of the population, not us as the 59% of the population. So when we're saying, how well are we going and what are the implications? If us is the 59%, all the good people, then they're none. But if us is the 41%, then I think we have to be slower than the New South Wales press release yesterday was headed the roadmap to freedom. And of course, the freedom for the 59% is a hospitalisation for the 41%. And so we have to think about a slower national plan rather than a faster national plan to reducing public health restrictions. Now, here is the national plan to transition to the national plan that everybody talks about. It is a magic document in the sense that this document means what anybody says it wants to mean, or if anybody wants it to mean something, this document allegedly says that. And so it morphs like a Harry Potter map. And so, for example, everyone knows that the national plan says that the state borders should be open up when we hit 70% or 80% of people vaccinated. Everybody knows that. However, there's no mention in this document that's on your screen about state borders at all. It's just not mentioned there at all. It's important to know that this was never approved by a national cabinet. It was approved in principle, possibly because they didn't know what they were precisely approving. And I just draw your attention to some other things. Everybody knows that the national plan says when we hit 70%, then we should do something or other. However, on the document itself, it says around 60%. It's got a tilde there, meaning approximately. So it's a vague document. Everybody knows that we ought to have easing restrictions on vaccinated residents. Well, it says here in the document to be determined. Anyway, but let's forget that the document is so vague it's meaningless. It is really a document that's guiding where Australia is going on the response to the pandemic. Importantly, what the Prime Minister says the document says and what the document actually says are two quite separate things, and you've got to judge in your own mind which one you think is more important. Now, a couple of points here. I support the idea that as we relax our restrictions, we should be relaxing restrictions more on the vaccinated than on the unvaccinated for a number of good public health reasons. So I support the idea that there should be vaccine passports, and that even though a fully vaccinated person can be infected and a fully vaccinated person can transmit the virus, they transmit it at much, much lower levels than otherwise. And I think in both New South Wales and Victoria, we are hitting the people's tolerance of the levels of vaccine restrictions that we're suffering. So slowing down the speed of lifting restrictions, but allowing some restrictions to be lifted for the fully vaccinated, I think is the right thing, but I think the New South Wales strategy is a bit risky. The other thing I want to talk about slowing down is about school kids. At the moment, there's no mention in here about schools. There's no mention in this document mostly about schools at all. There's no vaccine for people under 12 anywhere in the world. And there's no discussion about what we should be doing to protect school kids, people under 12, if we start to lift restrictions at, say, 56% of the whole population, which 70% vaccinated is. And, what are we doing about protecting schools? Are we talking about rapid antigen testing every day before they go into school? Are we talking about HEPA filter, improved ventilation and air quality in schools and so on? So there's nothing in this plan about any of that, and we ought to be protecting that population. This is from the Centre for Disease Control in the US. It's about the pandemic phases that you'd actually expect to see. What I want to draw your attention is that they talk about a recovery phase, and an important part of the vaccine preparedness and pandemic preparedness. Now, coming back to this document, what is startling about this document is there is no recovery phase whatsoever. It's just not mentioned. There's nothing there. There's a post-vaccination phase, but we don't talk about recovery. In a recent paper, there was some discussion about what a recovery phase ought to look like, and comparing a recovery phase from a natural disaster or a recovery phase from a vaccine crisis. And the sorts of things you'd expect to see in a recovery phase are something about business recovery, but we haven't seen any plans for that. You'd expect to see something about re-strengthening community capacity and providing mental health funding, and I'm pretty sure Pat McGorry is going to talk about that later on. But also you talk about how did we go? Did we assess how we went? And we're not talking about that either. So what I'm trying to draw to your attention here is that the plan itself, which is supposed to guide what we're doing, is a very incomplete, very inadequate, and very risky plan because it is incomplete and inadequate. Thank you very much.
Okay, thank you very much, Stephen. The next speaker is Peter Doherty. And go ahead.
Yeah, sure. So I've got 6 minutes, I think. So my expertise is in infection and immunity. That's what I've worked on for more than 50 years. And I'll say something about the infection and the immune response that may condition the way we think about this. Firstly, we're dealing now with a variant called Delta, which is much more infectious than the variants we dealt with early on, which means the lockdowns are no longer working. And basically, the virus is gradually taking control. The lockdowns are holding it down, but they're not stopping it. The R naught of the initial strain, which is about that of influenza, was about 2.3, 2.4. It's now up to about 6. So for those of us who are older, instead of spreading like flu, it's spreading like chickenpox. And we can't just lock down our way out of it. And the infection itself, well, the infection itself is we thought of it initially as a flu-like disease, though we were all saying it's not flu. But flu is an infection, it's a pneumonia. It gets in your nose and down into your lungs, and it causes pneumonia. And it can kill you, and it's a bad disease. But this disease, we realized after a few months, is a very different disease, because it's not just a pneumonia, it gives you horrible things in your lung called ground glass lesions. But it also gets into your blood and goes around your body in the blood. It's a clotting disease. It causes blood clots, it causes heart attacks, strokes, microclots that stop you getting enough oxygen. So it's a really crap disease, and it's a nasty virus, and it's a virus that's been speeding up its rate of spread, speeding up the level of infection, and basically is causing somewhat more severe disease, and it's infecting more little kids. With respect to little kids, we can vaccinate down to age 12 here, and we're going ahead with that. In the US, they're currently trialing it in children below age 12. We expect they'll probably start vaccinating early in the new year from the 5 to 11-year-olds, but that depends on the trial results, and we haven't seen those yet. So they will be vaccinating the younger children as long as the vaccine is found to be safe and effective. And unlike the earlier situation, which was much like influenza, which was very different from influenza, influenza is often brought into the household by a small child. That wasn't the case early on with COVID. When you got a household infection, someone in the house infected, often it didn't spread to all the rest of the household, and often the children didn't get infected, even if adult members did. It's no longer like that. As soon as this virus gets into a household, whether it's brought in by a child or by an adult, everyone gets infected. Everyone will get infected. Children, generally less severe disease, much less severe. They still sometimes end up in hospital, and we're worried about the numbers of pediatric ICU beds we have in the country, and the pediatricians and all the health professionals at the moment are really wondering how we're going to ramp up for exactly what Stephen described as somewhat of a fraud, the document that can be everything to everybody. And we can see Gladys making one thing of it and Dan making another thing of it. I'm more with Dan, I think. Certainly the 41%, that's us who are older, are still at considerable risk. We're vaccinated. The current vaccine is against the original strain. It's holding pretty well against Delta, but it's about 3 times less effective, which is why people are needing to be boosted. In Israel and the United States, they're now boosting the elderly. They're getting a 3rd shot. We haven't had discussion of that here. We should have had. But of course, our government is not very good at looking beyond about 3 weeks ahead, as far as I can see. They're absolutely hopeless. And so, but though I support them all the time, you can't have mixed messages in public health. I say what wonderful people these are, and then attack them on climate change on Twitter because they're a bunch of jerks. But apart from that, so when those of us who are older are still going to have to be careful. We can be infected, it can get up into our nose, and it can still be quite a bad infection. We can keep the antibody levels that the vaccine generates high in blood. And I think the reason we're keeping people out of hospital with vaccination is because we're stopping the blood-borne phase. We're stopping it going to the heart, to the vessel walls, to the kidneys. We're keeping it out of the blood. You can still get a pretty bad respiratory infection, and you can still feel quite sick if you're vaccinated, and you can still transmit. And you can transmit quite a bit, actually. So there's no herd immunity that we're used to thinking of about with other vaccines. People who are vaccinated will still be transmitting, and they can still transmit. So this is a virus that's completely new to us. It's done something we've never seen any virus do before. It's become much more infectious. And that's because it's been in what we call a virgin soil situation, where we've had no significant pre-existing immunity across the planet. Variants are coming through. It doesn't mutate at the rate of flu, but we are seeing variants come through like Delta, which just grow a lot more and grow a lot faster. And we're also seeing other variants that are around, but they're not taking over from Delta. The real question will be when we get enough people vaccinated or infected and they're immune, whether the virus will then have to jump that barrier and whether it will become milder. We're hoping it will, but there are no guarantees in any of this. And when we're talking about all these strategies and certainty for the future, basically there is no certainty. We have to follow. We are to some extent taken over by what the virus is doing. It's to some extent out of our control. But there is no real certainty in the long-term future about this. But of course, people want certainty. Why they're so delusional, I don't know. But you can answer that in the social sciences. Everyone in science lives with the rule, you know, if anything can go wrong, it will go wrong. And basically, that's the way my life's been lived. So there's something about the infection, and we're having a panel later, and I'm happy to answer any questions on that area. Okay, thanks.
Thank you. Thank you very much, Peter. The next speaker will be Professor Nancy Baxter.
Thank you very much, and thank you for this opportunity to speak today. And now I get to say that I've been on a panel with a Nobel Prize winner, so this is a great event for me. So what I'm going to talk about is in terms of the relationship of health policy and our control of the pandemic, really is that pandemics are not experienced equitably, and our failure to consider and address this has worsened the pandemic for all of us. And one of these example I'll give is, you know, I'm a 54-year-old woman. I have no pre-existing conditions. I am well able to work at home. I basically have embraced my inner hermit during this whole pandemic and have very little interactions with anyone. I live in a house with no shared ventilation, yet I am amongst the first 30% of Victorians to have been fully vaccinated. This is not a system that you'd put in place if you had any understanding of equity in terms of the impact of the pandemic, nor the risk of the pandemic, nor how pandemics are actually propagated in society, particularly during lockdowns. Yet this is what has happened. So I'm just going to talk a little bit, and I think it follows up on what Stephen has talked about how we prioritize vaccinations, how we think about how pandemics grow, and how our failure to, you know, understand our own experience and understand the experience that's happening globally has influenced how the pandemic has progressed, and our opportunities to kind of do differently and better in the future, and how that may determine how well we do as we open up. So when we think about equity and the pandemic, there's the relationship between who gets COVID and how serious COVID is for them, and who is prioritized for vaccination. So I'd just like to talk a little bit about who gets COVID and how serious it is for them. And this follows up a little bit about what both Stephen and Peter talked about. Well, first of all, you know, COVID depends on exposure. So it depends on movement and it depends on interaction between people. And so what we know is that when we go into lockdown, and this is something we experienced in Victoria, this is something you can look around the globe and you can see this, that once we are in lockdown or restricted movement, COVID becomes a disease of essential workers, their families, and their communities. And you can blame those people, you can blame those communities, but essentially if people have to go out to work, they have an increased risk of exposure to COVID. They bring COVID back to their families and their communities. And that is reality. And failure to recognize that reality has allowed COVID to propagate in those communities and also created this a framework, at least in some areas, less in Victoria than say in New South Wales, this framework of blame that really has created distrust amongst communities and has made it worse in terms of bringing those communities on board. You've had to do a lot of effort to kind of backtrack on what's happened at the beginning when it was all about bad behavior and not recognizing the fact that you have essential workers who have increased exposure to COVID as compared to me, who's fully able to do my job on Zoom. The other thing is the essential workers, because of the socioeconomic situation that they're in, that means they are part of the essential work structure. Also relates to the size of their household, the places that they live, all these things that also increase risk of propagation, of spread of COVID. So it's not just that these are essential workers, it's the reasons for these people being essential workers and the exposure that their communities and their families have. As Peter was saying, once Delta gets into a household, the entire household is infected. And what the contact tracers are finding now is by the time a case is identified, the entire family will be infected. And the fact that the entire family is infected means that there's more potential exposures within that community. Again, focusing the risk of the pandemic and transmission of the pandemic on a group that's already socioeconomically at risk. So then you have clinical vulnerabilities, and this is what Stephen talked about with 41% that's at increased risk. And this is also not equitably distributed, because we know that socioeconomic determinants of health, which are also related to the need to do essential work, these end up creating clinical vulnerabilities that will increase people's risk of COVID when they get it. So more likely to have serious disease, more likely to have serious sequelae. These are the people with pre-existing conditions that we keep hearing about, despite the fact that so many of us have pre-existing conditions, and everyone has someone in their life that they love with a pre-existing condition. Somehow, again, that's made to be, these people are not as important. Their suffering and death is not as important because they had some reason to suffer and die, which is not constructive. Then there's the inequitable access to the medical system. So many of these people that are at higher risk of contracting COVID in themselves and their communities and families, they're at higher risk of clinical vulnerabilities because socioeconomic determinants of health. They also have an a decreased ability to fully access the medical system for numbers of reasons that relate to language, that relate to the amount of time they have to work or care for their children or their family, and just the ability to negotiate the quite complicated system to actually get vaccinated, having to get on wait lists with GPs, having a GP that is vaccinating, being able to get access the computer systems to be able to get an appointment at state facilities. So we've created many barriers to access for the people who are, again, at higher likelihood of contracting COVID and higher likelihood of having clinical vulnerabilities related to socioeconomic determinants of health. And our vaccine prioritization. So Stephen talked about the magical document of our transition plan. There is also the magical document of the prioritization of our population for vaccination. So we all know we had the 1As, the 1Bs, the 2s, and everybody else. And they made sense. So you read the document and you said, yes, that makes sense. These are the population groups that should be prioritized because they're highest risk. But for most of them, other than aged care, there was a plan, but the plan had no implementation associated with it. So a good example is the disabled community. So despite, I think, uniform agreement that these are higher risk individuals and should be prioritized, there's actually no plan in place to make sure the disabled were vaccinated. And unsurprisingly, the rate of vaccination in the disabled is lower. Similarly, I don't think there was any argument that the Indigenous community was higher risk because of, again, their clinical vulnerabilities related to comorbidities, the isolation of some of these groups. So there was in the plan, in this magical plan, there was prioritization of Indigenous communities. Yet what we see is, in reality, until we started getting outbreaks in Indigenous communities, other than in Victoria, these were communities that had lower rates of vaccination than, say, communities of which I'm a part of. So the other thing that was not considered in this prioritization plan was really the fact that there would be these disparities in vaccination, and that they were more likely to affect groups that were at higher risk of having the virus transmitted, and also higher risk in their communities and families. And so what this means is that our vaccination plan, has resulted in increased risk in the particular groups who are most likely to transmit COVID and also most likely to suffer the consequences of COVID. So in fact, our prioritization plan, to some degree, although we have done an excellent job of making sure older Australians are protected, which has been very helpful, in terms of the younger groups, the lack of prioritization of those groups that are most at risk, both of contracting COVID and transmitting COVID and suffering the consequences of COVID, really has had a negative impact on our ability to control the outbreak. So how to move forward? So Stephen talked about making sure that 41% have high rates of vaccination, and I entirely agree with that. And part of what's been lacking in many of the models are pretty homogeneous. They do model things like household sizes and chances of bringing virus into households, but they fail to kind of really look at geographic and socioeconomic determinants of health that would influence both the transmission and vulnerability of people when they contract COVID. And so we really need models that allow us to really dive deeply into that. And we also need an equitable strategy to make sure if we're in this together, then we really need to be in this together. And we have to achieve equitable vaccination before we even think about what we relax at 80%. Because if we just choose a number like 80%, what we're going to make sure is that, rich people and influential people and people with access are well protected, and that everybody else, well, hopefully they've managed to find a vaccine somewhere. So we have to do much better than that. So we have to develop a strategy and plan that embraces equity when we think about opening up. So some things we need to do is we need to define priority groups. We actually need to have an implementation plan to make sure those priority groups are vaccinated. We should be looking at rates of vaccination across geographic areas, and we need to set benchmarks and targets so that we don't open until we are really equitable in terms of our distribution of vaccine. That achieving 80% for everybody just isn't good enough, as Stephen says. It's just not good enough. And what it's going to be is if we do that, we're going to increase the chance that the virus is going to spread widely amongst those groups that are not vaccinated. And we're going to increase the burden on our healthcare system and mean that we're going to have to be back in lockdown. So if we don't actually approach this in an equitable way, we are going to end up making the pandemic worse for all of us. And the other thing is, similarly, because the groups that will be unvaccinated won't be equally distributed, it means it's much more likely for outbreaks to propagate and disseminate. So again, making the pandemic worse for us. So that's what I'd like to end with. I think we have an opportunity now to make sure we bake in equity as we move forward. I don't necessarily think that's likely, and I think that will have a negative impact on the pandemic for all of us. But I do think we have the opportunity, and I think the people on this call all have voices, and we should all be calling for this.
Thank you very much, Nancy. And now I'll call on the last speaker, Patrick McGorry.
Thank you. Thank you so much. I might just share the screen. I've got a couple of slides as well. So I guess what I'd like to do is introduce a bit of balance into this. I understand why the discussion's been pretty much one-dimensional about the virus and limiting the pandemic, but we actually have a bigger responsibility for the whole spectrum of health conditions, not just, saving lives from viruses. And there is a tension here. There is a tension. We don't have chief health officers. We have chief COVID officers, and there's been a significant neglect of the rest of the health system in the context of the pandemic. Now, that would be a good thing to debate a bit later. For that reason, we've introduced the term the shadow pandemic, which was borrowed from the Economist magazine actually originally last year. And I'll come back to this in a couple of minutes. But the way we look at it, there have been three mental health impacts of the pandemic. One is on public morale. And I think someone earlier referred to the wartime analogy, where the management of public morale is a highly critical, and there's a lot of skills and other key variables that need to be attended to in managing public morale. It's been managed. You could see the ways it's been mismanaged, but in general, they have tried to pay attention to this. And everyone suffered from that. Every single one of us probably has suffered in some way from that. We've had a loss of well-being, if I can put it that way, as a result of the pandemic in many, many ways. Second thing is new incidents, new cases of mental health, mental illness that occur in any disaster. And this is a global disaster. And even in focal disasters, you see a 20 to 30% increase in incidents, which has a long tail. And this is a much more serious impact on that, and I'll show you some modelling in a minute about that.
Excuse me, could I please interrupt? Could you please put your show on slideshow?
I have, but it's not on.
You're seeing stuff on the side of the screen.
Oh, how do I do that?
Well,
Click on the bottom right-hand corner button down there, just a bit to the left.
Sorry, yes. I hadn't realised I hadn't done that. Sorry about that. Yeah, is that better?
Oh yes.
Yeah, sorry. Okay, so and the third impact is worsening of pre-existing conditions of mental health, mental illness. Now, this is the situation in Australia now. Prior to the pandemic, about 78% of us were disease-free from a mental health point of view. That's reduced significantly. You can see there, and it's across the different levels of severity, and all three categories have gone up: mild, moderate, and severe. And there's reasonably good evidence about that from surveys. Young people in particular are picking up on Nancy's point about high-risk groups. Young people are the high-risk group when it comes to mental health in this context, as they are in general across the lifespan. 75% of mental ill health appears by the age of 25, particularly in teenagers and young adults. And this group has been extremely hard hit by the pandemic. As you would know, this is some slide from YACVIC, the Youth Affairs Council, which shows all the differential effects, social, economic, and psychological, on young people as a result of the pandemic, and in fact, many other disasters are similar. This is modelling that was done by our people at Origin last year for the state government, predicting the rise in need for care. And you can see it's got a very long tail. When you talk about long COVID, this is long COVID for sure, because it's going to last for years, this increase in morbidity from a mental health point of view. We're already seeing it, and it's very much what's actually happened in the 12 months or so since then is pretty much exactly what we predicted in terms of the rising tide of new incidents. This is modelling from Ian Hickey's group at the Brain and Mind, which looked at suicide in young people, and it brought into play many different social and economic variables to predict what would happen. That's been moderated through things like JobKeeper and economics policy, but so far there hasn't been significant rise in suicide, although we are seeing signals of that now in young women in Victoria. And we've certainly seen a big surge of suicidal behaviour in young people, something like a 40 to 50% increase in suicidal behaviour coming into emergency departments. Surveys like this show most young people report their mental health as having deteriorated significantly during the pandemic. This is the emergency department data from Victoria in teenagers, showing very significant rises in presentations, most of which is, self-harm, suicidal behaviour. Eating disorders is another rising piece of incidents there too. So this was predicted, but unfortunately, the sense of urgency that governments have applied to the COVID response has not been applied to the mental health response, and I'll try and explain why before I finish. Now, it's great that Stephen's on this panel, because he was a key player in ensuring that Victoria's collapse of mental health care over the last 15 years was highlighted, and the government ended up responding to that with the Royal Commission, which reported earlier this year and led to a budgetary commitment of 3.8 billion over the next 4 years to rebuild the mental health system in Victoria. The problem is that we're trying to build on shifting sands or even a crumbling foundation, because the system is only just hanging in there now. It's got worse since the pandemic. The workers are exhausted. They've been deployed into other areas. The system's actually deteriorated at a very time when it needs to be stronger. And that's probably true across other parts of the health system too, but particularly in mental health, which was in very poor shape before. Just to give you one example, the headspace that I work in has got 200 young people on the wait list. And every weekend there's a surge of new cases presenting at emergency departments as well. So wait times, I won't go through all these factors in the interest of time, but we are trying to deal with an emergency from a very low base. And so that's the challenge that we have. Now, obviously, as everyone knows, vaccinations is one of we've got to get out of this lockdown situation, and we can't tolerate the sort of thinking that I don't think that Nancy was alluding to before. Certainly there are inequities, but we cannot delay, an exit strategy. You have to balance the benefits from the pandemic point of view against these other effects if we actually keep delaying and don't have a clear plan. And people need hope. They really need hope. But the capacity to do this and the sense of urgency from state and federal governments to tackle the mental health shadow pandemic is not at the same level as their sense of preoccupation and urgency with the main pandemic. So that's our struggle, trying to balance these things. And I know in other areas of healthcare, I've heard other specialties within medicine talk about the effect on cancer care and other major public health conditions of the pandemic and the focus on the pandemic. So it's not just mental health that's being affected in this way, but it is the number one thing. And mental health as a public health problem, as I've been trying to say, has been the most neglected of the big three: cancer, heart disease, and mental health. It's always been that way. So you might think that we're making a lot of progress, and we are probably in public attitudes, but we haven't seen that translate into practical reform that the public can benefit from. So I think, sorry, I'll just unshare there and I'll stop talking, but I just think this is something that hasn't been given enough attention at this point, certainly not by the public health community, and we've definitely been advocating for that. We do talk to government a lot, so we're trying to get this addressed at the same time as the pandemic's being addressed. So I'll stop there. Thanks very much.
Oh, thank you, Patrick. I wonder how Australia rates as far as its handling of the pandemic with other countries that have also had to deal with it. Maybe perhaps Sweden got it right after all. This, particularly given the mental health problems, the economic problems that Australia has faced with all these lockdowns. Did any panelists want to say anything about that?
I think if I just might start, Janna, in my view, Australia handled the pandemic very well, in contrast to England, who handled the pandemic very poorly, and we handled the vaccine rollout very poorly, in contrast to England, that handled the vaccine rollout very well. So we've done some things well and others not. And as Pat has argued, that if we have public health restrictions, there are costs of those public health restrictions and there are benefits of those public health restrictions. And for example, the mental health, domestic violence, alcohol and drug costs of public health restrictions increase over time. And so the issue for government is, how do we manage those costs versus the benefits that come from public health restrictions? I see Peter and Nancy want to say things, so I'll stop.
Yeah, I've sort of argued all along that what we're doing across the planet is different experiments in different countries. And we've done one experiment because we're an island and we were able to lock down. And as I agree absolutely with what Stephen just said, but I'd like to ask Patrick, what have the consequences been for mental health in countries like Sweden? And currently Germany is not going to lock down again. I believe they're having 10,000 cases a day and about 35 deaths. So do we have any comparator of what the mental health situation is in a situation where essentially the virus is just running free?
Yeah, that is a great question. I'm afraid I don't have the answer to it. I can say, even though I've been critical of the relative inaction compared to the action on the pandemic itself in Australia, that the action that has been taken in Victoria and Australia more generally has been better than most other countries in the world. You don't hear a mention of it in most of those other countries. So we're a bit more evolved, but we've still got a way to go, is what I'd say.
Yes, Nancy.
Yeah, I think we've been able to view public health restrictions in a very dichotomized way here. So it's lockdown versus not lockdown. And we've been able to think that not lockdown would be not with a raging outbreak, just because we've been very fortunate in terms of our management to date in COVID-0. But now we're seeing, as Peter said, with the Delta variant, that kind of no longer working for us. But I think when we think about all the other impacts that the public health restrictions have had and the pandemic has had on other medical conditions, and I'm a cancer surgeon by discipline, so it definitely resonates with me that there are lots of consequences of this. I think that this kind of dichotomized thinking that it's lockdown or it's, we're doing okay, fails to understand the global impact of a raging outbreak on absolutely everything. The grief associated with all the deaths. I mean, you have 600,000 dead people in the United States. No one hasn't been touched by that. I know people from Toronto that have died of this. So I think that there's a collective grief that's happening in these countries that have had outbreaks. There have been major disruptions in every part of society that has a massive effects in public health, in mental health in places where this outbreak has kind of raged uncontrolled. I do think that the other thing is in terms of lockdowns, many other countries have had to have very long lockdowns because of the totally out of control outbreak. And this is, I keep very close touch with, obviously, people in Toronto, having only left 18 months ago. And they spent much of last year in lockdown, much of the past academic year, children were out of school. And now with Delta, things are getting out of control again. So they're probably going to be in lockdown again. So I think it is a horrible situation that we're in. But I do think that the consequences for healthcare and mental health of a raging outbreak are extremely negative too.
I'll ask a question asked on Q&A by Alan Peterson. The idea of a vaccine passport is certainly gaining momentum, and there are good reasons for favoring it. But what about the discriminatory implications, especially as regards those who, for religious, health, or other reasons, do not get vaccinated?
What are the religious reasons?
I don't know. There might be. There's certainly the reason that the vaccine has been made from aborted fetuses or something like that.
Well, at least the Pope has said that it's legitimate to use. I'm not aware of a religious reason.
That only applies to the AstraZeneca vaccine.
And the Pope said it's okay. So
the Pope said it's fine.
I'm not aware of a religious reason.
And similarly, there are almost no health reasons. But the point is, the underlying point is when our vaccination passport, the point of a vaccination passport is that it allows freedom for some ahead of freedom for some ahead of freedom for everybody. And so it's a matter of timing. So you might have more restrictions for some people and less restrictions for some people over a 2-month period, but the benefits are for everybody. That is, while you continue the public health restrictions, everybody benefits, but you allow some people some lesser restrictions over a shorter period of time. And my view is, if it's 2 months, it's 3 months. That's an inequity that we should wear.
Yeah, I mean, my sense is we just want to get everyone vaccinated if we possibly can, because the type of thing that Nancy and Patrick have talked about, the pressures on the healthcare system, it's the unvaccinated who are now going to put massive pressure on our healthcare system. And that's going to mean all our ICU beds are full if we're not careful. And of course, remote communities are tremendously at risk. I think the Northern Territory has been quite good at getting vaccines into Indigenous people. But with the exception of Victoria, clearly that hasn't been so well emphasised in many other states. But I'm enormously worried about small and remote communities, places with one nurse or one doctor. I mean, what happens when you take out that local medical service? I mean, air ambulance. This is a problem that's unique to us. Nobody else has these massive distances and these small remote communities where you can only really get people out by air ambulance. I think, well, maybe Canada, but really, I think that's a tremendously difficult area. And it always amazed me that these weren't being targeted very carefully. And also, I mean, the vaccinating the people in the old care homes. Teams should have gone in there to vaccinate the elderly, but also vaccinate the workers. And I couldn't believe that when I heard it, because debate always was in my mind, which should you vaccinate first? The workers who are going to bring the virus in, or the elderly who are susceptible?
I will ask a question that was asked by John Dobb. I'd be very keen to hear the panel's thoughts on the mental health and well-being of the elderly and how this has been impacted by the pandemic and policy responses or failures, particularly those in aged care facilities.
Well, this is something that I feel very deeply. My mother is in an assisted living facility in Toronto. And basically, they had huge outbreaks in aged care, similar to here, but much more widespread, horrific deaths and suffering in aged care. And so my mother's aged care did very well during the pandemic in terms of protecting people, but it went into lockdown. And it was in lockdown for 9 months, even after vaccination of the people in aged care. She's suffered. Definitely her early dementia has worsened. And at some point, she kind of had basically lost the will to live, although, not suicidal. She was just continuing on. Things are better now. Things have opened up and she's having a more normalized life, but I think it's had a permanent effect on her.
Maybe I can jump in, support Nancy. Obviously, that they're another very high risk group from a mental health point of view as well. Can I just jump back to the issue that you raised? I just want to agree with Nancy and Peter about a completely unrestrained pandemic with mass death is terrible for mental health as well. I didn't want to be suggesting otherwise there, but I had understood that we're in a very different situation now with the vaccines. Once we get that vaccine saturation sort of level, whatever it is, we will be in a situation where the case fatality will have gone down. The risk situation is very, very different from what happened earlier in the pandemic, and that's when you have to start balancing these other health conditions. That's what I was trying to say.
Helen Berry asks the question, if there's no certainty for controlling the disease in the long-term future, what should our recovery phase look like? She's particularly asking Peter and Stephen, but other panelists may have an opinion too.
Just from the scientific aspect, I think we will be giving booster shots. I think we will be seeing vaccine against variants. Pfizer is currently making, and Moderna are making the vaccine against Delta. It may not be Delta, though, that we have to deal with. So I do think we'll be seeing regular boosters. I'd also say that I'm 80 years old, and I think people of our age are still going to have to be very, very careful, because our immune systems decline with age, and the vaccinated people who are dying in the US and so forth are generally the frail elderly, actually.
So my answer is that it'd be actually good to have a recovery phase. That is, the government should be the governments, plural, that is Commonwealth and state governments, should be thinking about what a recovery phase ought to look like. It ought to have a number of components, one of which is a recovery of the economy. As if you just walk around the streets of Sydney or Melbourne, you can see that the economy is taking a hit. So that's the first point, and the premature ending of JobKeeper is an example of the sort of thing that they should have continued. The second point is, as Pat said, the recovery phase ought to include what are we doing about mental health and increased investments in there. The Commonwealth Government has done a little bit of fig leaf here on the head help programs in both Victoria and New South Wales, but they are just a fraction of what is needed. Thirdly, we have to think about the community recovery as a whole. What are we going to do to restore a joie de vivre or something? You know, how do we bring the community back? And when a whole lot of businesses have closed and a whole lot of and our behaviours have closed, and we've, as Nancy said, we've all embraced our inner hermit. How do we actually create social solidarity through our activities? And while I've got the floor, I'll say I actually have to leave to chair another meeting at 11 o'clock, so I'll be signing off very, very quickly.
Well, that's fine. You can sign off anytime you want, and this panel is due to end at 11 o'clock in any case. But I'll ask a question that Ian Hickey is asking. In planning a recovery reconstruction plan, how do we prioritize the reduction of social, economic, and healthcare inequities that we've long tolerated in Australia? Now, that's a big question, but if people have a few sentences to say on that, that would be, I think it's a very excellent question to ask.
As I understand it, we're still focused on cutting taxes for the rich, and that's the kind of government we have. So I've got an enormous Twitter following now, largely due to some rather strange events and being rather foolish. But I'm keeping it going, hoping I can get rid of the current government at the next election.
Yeah. The trouble is, it's deeper than the current government. It's neoliberalism, which has taken over the last 40 years. And I was reading a book by, or several books by Mariana Mazzucato about what's wrong with the whole sort of, not just the capitalist system, but the way we've been operating more generally. So unless that gets addressed, and I can't see how it will be politically, maybe other greater minds than mine will know the answer to that question. But that, I completely agree with what you said, Peter, and also with what Ian's hinting at there.
I mean, I'm actually concerned about a period of social unrest and violence. It's starting to happen now in Canada. They have an election that's ongoing, and people have been throwing rocks at our Prime Minister. So I think that we do have to focus on societal cohesion and find ways to bring us all together. Otherwise, we are going to splinter apart, and it's not going to be good for the pandemic, that's for sure.
We're almost finished. If anybody have a comment that they would like to make in the last few minutes?
Maybe just have someone have something optimistic. That would be good. A good way to end it.
Despite what I've said, I am quite optimistic. Maybe without really much support for that. But I do think we may be in a much better space by this time next year, that we will have to go through a certain amount of fire with this commitment to 80%, because we've seen what happened in Israel and Singapore and various places when you tried those sort of games. But I do think we may be, once people, perhaps the best immunization of all, and I'm not advocating that anyone should do this, is to be vaccinated and then be infected.
Yeah, I could say an optimistic thing too, Janna. I think we're very lucky to be, those of us living in Victoria, to be living in this state from a mental health point of view, because at least the government's admitted its failure and it's putting a lot of money into it. We've just got to get the workforces and we've got a great blueprint coming out of the Royal Commission. So I do feel optimistic compared to the last sort of 10 years of frustration in mental health.
From my perspective, oh, sorry. I was just going to say, from my perspective, I think that the progress in terms of scientific solutions has been unbelievable in terms of its pace. And I think it'll continue to be fast-paced with new vaccines targeted towards variants or targeted towards coronavirus in general, and better treatment. So I do think there's likely to be more game changers in the future that will, that's what I'm optimistic about. I'm more optimistic about the science than I am about equity.
Okay.
I mean, in some ways, what we've done here is going to transform a lot of our healthcare system. I mean, we've never done this PCR testing of everyone before. Now, if we did that with influenza, if we had an influenza outbreak, we PCR tested everyone with the sniffles. We already have drugs that will block influenza if you give them early. Drugs like Tamiflu. You could actually stop an influenza pandemic if we did what you did with COVID. And the drugs are being developed. There's a big National Institute of Health program to develop drugs which will work across all the coronaviruses, all the henipaviruses, filoviruses. These viruses threaten us as pandemic viruses. So in the future, and maybe next year still, we will start to see drug coming along. If we had cheap oral drugs that you could give to people as soon as they got infected, you would stop this thing and you would stop it in the future. So I think science does have a big part to play. But what I would also like to see happen is across the planet, every discipline from the social sciences, economic sciences, politics, and of course, our type of science, looking at what's happened here and really learning from it. And I think there's an enormous amount that people in the academic community could do to actually put forward much better policy situations. I mean, one of the things that occurs to me is in Australia, we have no mechanism whatsoever for long-term planning on anything as far as I can see.
Well, that's true, despite of the intergenerational report. Thank you, panelists. Thank you, Peter and Patrick and Nancy. And I didn't get a chance to stay. Thank Stephen, but this has been a very interesting discussion. Thank you.